to ask about where is it? When was the onset of the chest pain? Intensity, can you describe me the intensity out of 1 to 10, with 10 being a very severe chest pain? Any aggravating factors, any relieving factors? Okay, have you had this before? Right, you've done chest pain, put it to the side. Okay, then comes any associated symptoms. Along with the chest pain, have you got any other symptoms such as headache, nausea, vomiting? Patient might say, no. Okay, finished. So introduction done, identity done, chief complaint done, associated symptoms done. Then comes your review of systems. That's where the marks are, the review of systems. In a sense, in importance, you have to ask from head to toe all the symptoms, right? The most important symptoms you need to ask. So how do we ask? I've seen candidates spend 3 minutes just on the review of systems. Remember, out of 6 minutes, if you spend 3 minutes on the review of systems, you're going to lose marks. You're going to lose marks on past medical history, surgical history, medication, allergies, travel history, social history, occupational history, marriage history, alcohol, smoking. So you're going to lose marks on those, okay? Marks on those, okay? So review systems, how I do it, I will show you in the scenario. So the review of systems have certain chunk of marks. Then the past medical history, past surgical history, medication, allergies, travel history, in children's, immunization history, in females, menstrual history, in gynae case, PV bleeding, that's a separate topic. So all of these carry certain marks, they carry 1 mark each, okay? So this is your checklist. In the end, you need to ask this. I normally use this phrase quite commonly. I used to use this phrase quite commonly. Is there anything in the history that I might have missed that you might think is important? Please let me know. By doing this, I'm covering all my shortfalls. I mean, I might not have asked about shortness of breath, and the patient might have had a short of breath. So all of a sudden, the patient is duty bound to tell me he's got shortness of breath. And the examiner knows, hang on, this guy knows how to play OSCE game, right? He's covering all his bases. I cannot not give him a marks for asking this question, right? You will have to get a mark, okay? Now, in the end, you need to make sure you've asked this question. Have you got any specific concerns? Right, there we go. You've got one more tick for asking concerns, okay? Then you talked about, right, Mrs. Smith, I've taken a history from you. Just to summarize, you have this, you have chest pain going for 4 days, it's sharp, associated with this. So I've done a summary, okay? Is that correct? If you have missed, she will add a few points, okay? So another checklist done. I think based on the history, I think these would be the top 3 differential diagnoses, but I would like to examine you in front of a chaperone, because she's a female, okay? After examination, I would like to do some basic investigations, such as full blood count, FBC, urea and creatinine. Because you're coming with chest pain, I think troponin is very important to be done here. ECG you need to do just to make sure your heart's okay. I would also like to do a chest x-ray just to make sure your heart shadow is okay, your lungs are fine, okay? Will that be okay with you? Right, so you finish off. One thing I forgot is, which in the rhythm I forgot, if somebody complains of pain at the start, in the chief complaint, either it's chest pain, headache, abdominal pain, you have to all of a sudden ask, Mrs. Smith, I'm so sorry you were having chest pain. Would you like any painkillers? Right, there we go. The examiner knows, the candidate knows you are an excellent doctor because you are empathetic, you are caring, you want to look after the patient. Most of the times, the patient will say, no doctor, it's fine, okay. Or if they say, yes, I would like some painkillers, then you can say, okay, Mrs. Smith, I will just go and ask the nurse to give you some medications after I prescribe them. Is that okay with you? She would say yes, then you carry on. Now, if you follow this basic template, you shouldn't be able to fail. I mean, if you have good communication skills, You've done all the human factor things right. You are soft-spoken. Your body language is nice. Is not aggressive. Your posture is soft. Is a neutral posture, and you've done all the important questioning. You should pass the exam, right? It's as simple as this. Now, coming back to that question, do checklist changes every time? Yes, there will be slight modifications depending on who's making the exam, what is the theme of that exam, that session, or that, spring or autumn, whatever the theme is. But all in all, 90% of the time, the checklist will be the same standard checklist, but you won't believe me, right? That checklist is with every candidate in the world, right? But they still don't pass the exam. Why don't they pass the exam? Because they're not focusing on the other things. They're not focusing on completing the checklist in a timely fashion with the good communication skills, right? You have to practice. Once you do this, you should be able to pass the exams, okay? Right. Okay, so we were supposed to take a 10-minute set break, but if you guys are okay to carry on, I think we should just carry on. Alright, we're just going to carry on. If somebody wants to leave, they can come back. It's up to them. It's a total scenario. Okay. Now, yeah, sure.
I have one question.
Yeah, please.
Yeah, suppose if the patient comes with chest pain or some kind of pain, if we forget to offer the pain medication and initial introduction, so then later during the interview, if you offer the pain medication, are you still going to get the mark, or it's only we have to give an initial introduction?
Okay, thank you for that question. Okay, so it happens like it happened to me. I forgot to ask about the painkillers, but in the end, so when I talk about you finishing your history within 5 minutes on an autopilot, what you gain is an extra 1 minute. Okay, that 1 minute should be utilized by you for polishing off these things. Like for example, you haven't asked about the pain relief, then you go back and I'm really sorry, Mrs. I'm really sorry, Mrs. Smith. I forgot to ask, but would you like some painkillers for your chest pain right now? It's absolutely fine to ask in the end, right? It's absolutely fine. This is a myth that the examiner won't give you a mark. Once you have in your allocated time ask a certain question, the examiner is duty bound to mark you. Right, with most of these sessions, especially in COVID scenario, might be recorded, okay? So if a candidate goes back and challenges their marks afterwards, and they look at the recording and they say, he asked a question about pain, even though afterwards, but he's not been given a mark, so you might get a mark. But most of the examiners, once you ask that question, even in the end, in your allocated time, you will get a mark. What you can't do, once your 7 minutes are up and the bell rings, you're going out of that station, but all of a sudden you remember, I haven't asked chest pain. You turn around and say, sorry, Mrs. Smith, can I just ask you for painkillers, pain relief? Now that you won't get a mark because the bell has rang. Your time is finished. Once your allocated time is finished, you finish. Anything you do afterwards doesn't count. You have to do before that. So it's absolutely fine to ask questions afterwards if you have forgot. Okay? Right.
Hi, Mashhood.
Yeah.
I have a question. I'm Dr. Prakash. Can I ask?
Yeah, sure. Please, Dr. Prakash.
Actually, when I gave the exam last time, I got a patient with abdomen pain, and I actually asked the examiner, the patient that you have any pain, what's your pain, so I asked, and he told this is what my pain, and I gave the medicine. Is it necessary to ask at the end of the station whether your pain is subsided?
You're talking about the history station?
No, it's a history station, yeah.
A history station, right?
Yeah.
Yeah, no. You don't have to ask whether your pain is subsided, right? What you just have to mention is, if you have pain, would you like any painkillers? If yes, I will go and prescribe, and I will get the nurses to give you the painkillers, okay? examiner might say, well, first we have to remember the role of the examiner. Okay, I should have mentioned that before. I'll come to that answer. The examiner is there just to observe you, right? He's not your friend. He is not your enemy. He's just there to observe you, how good or bad physician you are, right? He will judge you on what you do on that day, but you have to make him be on your side. How you're going to make him on your side is if you have the politeness or the mannerism or the communication skills which are required for the exam, right? So examiner is there not to fail you, not to pass you. He will be only guided what you perform in that 5 to 6 minutes, right? So that's what you need to understand. Now, as far as the checklist is concerned, it just, for the pain, it just mentions, has the candidate offered analgesia? That's all. What it doesn't mention is, did the candidate reassess the pain afterwards? No, okay? That might be true for examination stations or resuscitation stations if somebody has pain and you have given painkillers and you are there physically to examine the things, but not necessarily required in history stations, okay? I hope that is clear. I hope you guys, no problem. I'm sure you guys know the role of examiner. I don't have to tell you. There is a misconception. The examiner is there to, there's a myth, I hear it all the time. I failed my exam because of that examiner, he didn't like me, right? Right. Well, there's a reason he didn't like you. He didn't like you because you might not have spoken softly, you might not have the human factors, you might not be sitting in a neutral position, you will be asking questions, but you might not be giving time for the patient to reply. The worst thing you can do is, and you guys will come across in psychiatry stations, I hope you don't, but sometimes they do, a psychiatry patient comes in, they just like to talk, okay? They're deliberately talking to waste your time, okay? They don't want you to ask more questions. It's quite typical of certain psychiatry manic stations. If somebody's manic, they will just talk, they will move around the room, they will not allow you to ask questions. Now, how do we deal with this? Because it will be rude if you grab hold of the patient and make him sit down. It will be rude if you tell him, can you please stop, I need to ask certain questions, okay? So this is the skill. You need to ask, you need to do this in a very subtle manner. When we're going to be doing our psychiatry stations, we're going to talk about the skill set which is required to tackle these problems, okay? Right. So what you don't want to do is, if the patient is talking, you rudely interrupt. If you rudely interrupt, you will lose a lot of marks. Previously, historically, I know this for a fact, historically, for example, a station has 30 marks, right? 20 marks were allocated to the checklist, 5 marks were allocated to the examiner's impression of you, and 5 marks was allocated to the candidate, the patient's impression on you, okay? When I did my FR Chem, that got redistributed. Then the 25 marks were given to the checklist and only 5 marks were given to the examiner. What the college did was took out the 5 marks of the perception of the patient because there was objection that the patient might be biased for certain reasons, okay? I'm not going to disclose right now because it's a public session, but so it's open, clear playing field for every candidate. You go in, you do your checklist, you do your communication skills, you follow a set pattern. That's why I want to emphasize hard work, but hard work in the right way, in the right manner. You should have the mannerism of communication skills. Once you nail the communication skills, trust me, every other station will be a walk in the park. You just have to then communication skills become a second nature, right? Then once you pass this OSCE, you will practice this in your clinical field. and that will transform you. So these exams are important exams, okay? I hope I've answered that question. If I have, if somebody has any other questions, please feel free, because I'm actually enjoying the level of the questioning, because these are very practical questions which candidates face every time. So please feel free, yes.
Dr. Mashhood, good evening. I am Dr. Barosh from Saudi Arabia, and nice to meet you. And I would like to ask that, according to the schedule we have sent, today we are going to talk about communication skills. So my request is that it would not be better to have our queries regarding the specific kind of patients, because as you said that we have lots of things in our mind, right from the start from the history and examination and so forth. So I would like to request that it would not be better to ask about specifically today about the communication station.
Okay. Oh, very well pointed out, sir. All noted. What we're going to do is we're going to close this question and answer session now, and we're going to move on. If you guys don't want any breaks, I'm happy to carry on. I'm going to carry on with my first scenario, if that's okay with you guys.
Please carry on, sir.
Okay, excellent. So, sure. So I have a patient here with me, right? So I will talk about this one. Okay? All right. I will read out the scenario to you guys. Then I will go out, and then I will come in as a candidate. And I have a patient in front of me. She will be answering my questions. Her face, for privacy reasons, is October. It doesn't matter if you see the face or not. But what's important is you see how I act, how I ask questions. Okay. Then we will discuss about this after we've done it. We're going to do debrief. Okay. The scenario is, I've already mentioned that I go in. I'm just going to read out. 55-year-old Mrs. Smith presented to the emergency department complaining of chest pain. She has past medical history of diabetes and hypertension. Vital signs are blood pressure 122/68, heart rate of 60, respiratory rate of 16, oxygen saturations of 99% on room air. Please take a history and discuss the management plan. Okay? Right. So as you can see, I'm going to be a bit more software techy from the next session. Okay? So if you can see this pie from here all the way here is history taking. So it's approximately, you will get sort of a picture like this in the station, which will show you the distribution of the marks. So the most of the marks in this station is history taking, which constitutes 70% of the marks. Okay, 30% of the marks is for the management plan for this patient. Okay, so all of a sudden I'm clicking is a history station. Most of the marks are for history. Okay, I'm going to time myself. I'm going to give myself at least 5 minutes. Okay, just go out and then okay. Hello there, Mrs. Smith. My name is Dr. Mashhood, one of the emergency medicine registrars. Can you just confirm your name, please?
Yes, I'm Mrs. Smith.
I can just confirm your date of birth.
Yeah, it's 1960.
Sure. Mrs. Smith, can you just ask what brings you to the emergency department today?
Well, I've been having some chest pain in the center, and that's it. I've been experiencing it since morning.
I'm sorry to hear that. Would you like any painkillers for your chest pain?
Yes, if you think so.
Sure. What I'll do, Mrs. Smith, is I will, once I finish this scenario, I will go and prescribe some painkillers, and the nurse I'll make sure the nurse gives you the painkiller. Will that be okay?
Yes.
Okay. Can I just ask a few questions about chest pain, if that's okay?
Yeah, sure.
Okay. Can you describe this chest pain? Is it sharp, dull, or is it burning in nature?
No burning. It's a bit sharp in that's it.
Okay, and whereabouts is it?
It's in the center of chest.
Does it go anywhere? Does it go to the right? Does it go to the left?
No,
Does it go to the back?
no, it stays
Okay.
there.
And Ms. Smith, does anything make it worse, such as breathing, moving?
No, nothing at all.
Does anything make it better, such as
No, nothing
resting?
is making it better.
Okay, all right, understand. Along with this chest pain, have you got any other symptoms associated with it?
No, nothing. I just have diabetes and hypertension, that's it.
Sure, okay. Now, I'm just going to ask a few more questions. Ms. Smith, have you had any headaches?
No, no headache.
Okay, any blurred vision?
No,
Any runny nose, sore throat?
no, nothing.
Okay. Any pain in your neck?
No,
Any swelling in your neck?
no,
Any shortness of breath?
no,
Any cough?
no,
Okay. Any abdominal pain? Or
No,
tummy
nothing.
pain? Okay. Do you feel sick or have you been sick?
yes, I feel sick because of this pain, but I haven't been sick otherwise.
And are you opening your bowels okay?
Yes,
Okay. And then you're passing urine okay?
Yes.
Okay. Have you noticed any lumps or bumps anywhere?
no,
Okay. Have you noticed any weakness of the arms or the legs?
no.
Okay, that's fine. Just going to ask a bit more questions about your past medical history, if that's okay. You've just mentioned you've got diabetes and hypertension. Is there any other past medical history that might be significant?
No, just that's it.
Sure. And you take medications for these two?
Yes,
Okay. Have you had any surgeries done in the past?
no surgery.
Okay. Are you allergic to any medications?
No,
Okay. Have you traveled abroad recently?
no,
Okay. And just going to ask a few personal questions. Do you drink?
no,
Do you smoke?
no,
Okay. And are you married?
no, I'm divorced.
Okay. And what work do you do?
I'm a housewife. I mean, not a housewife, I stay at home.
Okay. So, Mrs. Smith, what I could gather is from the history that you complained of chest pain, which is central, which does not get worse with anything specific, and you've got a history of diabetes and hypertension. Is that correct?
Yes.
Okay. A couple more questions about chest pain, if that's okay. Can you describe the intensity of the pain out of 10? 1 to 10, with 10 being a really severe pain.
It's 6.
6. And what time did it come up, this chest pain?
This morning, while I was working, making myself
Sure.
some breakfast,
What time exactly?
at around 9.
9 o'clock, okay. Ms. Smith, is there anything else in the history that I might have missed that you might think might be important?
No, I think you've covered.
Sure. Okay, thank you very much. Is there any specific concerns you have apart from the chest pain?
No, I would just like some painkillers if you think it's okay.
No problem at all, Ms. Smith. I'll just go and prescribe it and I'll make sure the nurse gives it to you. Ms. Smith, what I would like to do now is I would like to examine you. I will get a female chaperone to be with me when I do my examination. Once I've done the examination, I would like to do some investigations. These will include full blood count, looking at your hemoglobin levels and looking for any infection. I will also like to look at your kidney function. I will also like to do a specific test for the heart, which is called troponin. I would also like to do an ECG, which essentially looks at the tracing of your heart. And I would like to do a chest X-ray to look at the lungs and heart shadow. Would that be okay with you?
Yes, that's fine.
Okay. Thank you very much, Mrs. Smith. If there any, I'll come with the nurse, examine you, and I'll make sure the nurse brings the medications with you for the pain. Is that okay?
Thank you.
All right. Thank you very much, Mrs.
Thank
Smith. Thank you. Okay. Okay. Right. So I still have 2 minutes to go because I finished this session, this questions history within 5 minutes. Okay. So in the last 2 minutes, I'm sitting there. I'm just going through my checklist again. Is there anything I might have missed? Like you might have remembered, in the end, I did not ask the time of onset of the chest pain, and I did not ask the intensity of the chest pain. So I went back at the end and I finished off these 2 questions, which I thought were important, which I had missed earlier on. Now, I have discussed the management plan with Mrs. Smith. I've told her I will come back and examine her with the chaperone, and I will do FPC looking for the hemoglobin and infection, kidney function, troponin, ECG, chest X-ray. And then we'll come back and make a managerial plan. Right. So what I did, I'll tell you guys what I did, then I will open the floor to you guys. I went in pretending, or not pretending, you might have used a gel outside, so you have to just make sure you are rubbing your hands when you come in gently, okay? Then what all we need to do is to do a very good introduction. Hello, Mrs. Smith. My name is Dr. Kazi, one of the emergency medicine registrars. Okay. So once you've done it, your introduction should have your name, should have your title, your role. So that if you're sitting for an MRCEM exam, it's always safe to say I'm an emergency medicine registrar, because that's what the level they're judging you at. If you are doing at the FRChem level, it's quite safe to say, hi, my name is Dr. Kazi, I'm the emergency medicine consultant, okay? But if you don't want to do this specific title, some doctors they want to play safe. What they tend to do is, hi Mrs. Smith, my name is Dr. Kazi, one of the emergency medicine doctors, which is also fine, okay? But what you want to do is to take your name clearly and your designation and where you work. That should be clear, okay? Now, first things first. Once you enter, you need to make eye contact with the patient, okay? All throughout the history, you need to keep on making eye contact with the patient. This will tell the patient that you are confident and you know what you're doing. That would not be the time when you look down on the floor, look on the left side, look towards the examiner. There's no point at all looking towards the examiner, because the examiner is not going to help you in here. So it would be advisable if you guys can make eye contact with your patient. Now, your posture should be a neutral posture, right? Now, what you don't want to do is sit upright. Okay, what you don't want to do is sit all the way forward. It needs to be somewhere in the middle, right? Okay. Now, I used to have a habit, I still have a habit of moving my arms everywhere when I talk, okay? Some of the candidates also do, that's the way it is. But what you can do is, you need to grab hold of your hands somehow, okay? And put it on your thighs. So even if you have to ask questions, you just go one hand here and come back. One hand here, come back. What you don't want to do, your hands are flying all the way around, okay? Right. So we talked about the introduction, we talked about a neutral position, we talked about hand placement, we talked about eye contact. On the day of the exam, you need to dress appropriately. Now, wearing a tie is absolutely fine. Wearing a coat, you have to put the coat to the side. Wearing a tie is fine. Some candidates come with scrubs, which is absolutely fine. But remember, it's a professional exam. Whatever you're wearing, you need to make sure it's ironed out, it's neat and clean, and you have a name badge around. It could just be saying Dr. Mashhood Kazi, emergency medicine. Okay. You can get a name badge made anywhere outside, okay? You don't have to put designation, because the same badge you can use in PLAB, you can use in MRCEM, FRChem, you should make a neutral badge. Dr. Mashhood Kazi, emergency medicine, okay? Depending which exams you do. So you need to have a clean scrubs, clean set of clothes, a name badge. You need to have a stethoscope around it. Make sure the end of the stethoscope are clean. It doesn't look dirty, okay? Because it's a professional exam. You are impressing yourself. The candidate, the examiner, the patient needs to be impressed by your persona, your personality. It's not just about the personality. You need to have the skills to do that. But impression, human impression, physical impression also counts a lot, okay? Right, we talked about introduction, we talked about opening line, we talked about neutral position. Then what I did was, the next thing I did was, I confirmed the identity of the patient, all right? I asked the name, and I asked the date of birth, okay? What you don't want to do is just go in, hi, I'm Dr. Mashhood, I'm the emergency medicine consultant. What brings you to the emergency department, right? You have skipped the identification of the patient, okay? There might be a tick mark, I'm not saying there must be, there might be a tick mark for checking the identity of the patient. Even if it's not there, it's a good practice that whoever you're consulting, even in daily practice, you confirm what the name and date of birth of that patient is, because what you don't want to do, take a history from a wrong patient, okay? If you start making this habit from now on, if you start introducing yourself appropriately, you start checking the identity of the patient, if you just make it a habit, it will help you in all the communication stations. It will help you in psychiatry, breaking bad news, history taking stations, okay? Then I focused on the chief complaint. Now, opening line is important. Some candidates do it differently. I normally tend to do is, Mrs. Smith, what brings you to the emergency department, okay? Some candidates might do, Mrs. Smith, what seems to be the problem today? Okay, some candidates might do, Mrs. Smith, how can I help you? Okay, these are all fine. It's your personal preference, okay? It's asking the same question. It's asking the question, what is the chief complaint, okay? But I just think it's nicer to say, Mrs. Smith, what brings you to the emergency department? The other thing is, if you have noticed that, I don't know how am I coming across in the video, I'm trying to be very polite. I'm trying to ask questions in the clear words. I'm not using any complicated jargons. I'm just using simple English. Because my English is not my first language, that's absolutely fine. I mean, it's not a compulsory criteria that English needs to be your first language to pass these exams. But what's important is you talk them in clear, simple words, okay? Because remember, that is the layman, that is the patient who is a general public, he doesn't know your terminologies. So, I mean, we just need to be a bit more realistic, okay? I normally tend to say, what seems Mrs. Smith, okay, the other thing is, you need to have a habit of asking the patient by the name, okay? Like if the scenario says Jane comes to the emergency department or John comes to the emergency department, you need to start being in the habit of asking, so John, hi John, what brings you to the emergency department, okay? First you need to start remembering the name, what they're using in the station outside. That's one thing you can memorize when you go into the stations. You start using that first name. If you start using the name, it just gives you a bit more rapport with the patient. Right, so I've identified this is a chest pain. Then all of a sudden, autopilot, I go in and nail all the questions which come with chest pain, which is Socrates, which could be the site of the chest pain, the onset of the chest pain, the intensity of the chest pain, the aggravating factors, the relieving factors of the chest pain, right? So it doesn't matter whether it's chest pain, you can put just abdominal pain in that context and you will have to ask the same questions, just Socrates, the site, onset, intensity, radiating, aggravating factors, okay? Once you have to spend a couple of, at least 30 seconds to a minute fine-tuning the chest pain, okay? After you're comfortable, you've asked all the questions about chest pain, you need to ask about associated symptoms. Is there anything else about the chest pain which is bothering you? Okay, they might say dizziness, then you need to ask a couple of questions about dizziness. What you don't want to do is dive into dizziness like you dived into chest pain. Remember, chest pain is the main complaint, not dizziness. Dizziness is an associated symptom. So you can ask a couple of questions, they need to come out because there are loads of other questions you need to ask. So if you've done chest pain, you've done associated symptoms. Then comes the review of systems. Now there are two ways of tackling review of systems. Either you go system-wise, or you go from head to toe. I prefer, my personal preference is going from head to toe. I'm looking at the patient, I'm just saying, I'm starting the head to toe. I'm just seeing the head and saying any headaches, any blurred vision, any ear pain, any nose pain, and any nasal discharge, any sore throat, any neck pain, any lumps or swelling in your neck. Okay, and I come to the respiratory, any shortness of breath, any cough, right? Then I come to the abdomen or gastrointestinal, any abdominal pain. Now, it's absolutely fine to ask the questions, are your bowels okay? Now, you can also ask, are you constipated, you're opening the bowels okay, you've got diarrhea. Instead of asking those questions, if you just ask one simple question, are your bowels okay? They're going to say, yes, it's okay. That means they don't have diarrhea, they don't have constipation, okay? Then you can ask urinary symptoms. Have you got any urinary symptoms, both in males or females? Okay, it comes in genital urinary review of systems, okay? Then any weakness or pain in your arms or the legs, okay? Now, I ask this particular question, any lumps or bumps anywhere? The reason I ask this question, any lumps or bumps anywhere, that means I'm covering the skin. I mean, is there any swellings anywhere, any rash, things like that? So it's a way of asking a broader question in a short sentence, any lumps or bumps anywhere. Once I know I've done the review of system, then a couple of phrases you need to think about. The first one is there any specific concerns you have apart from the chest pain? I mean, it might come up, they might have a few things that you might have to think about. But if it comes, it's a lucky day because you have saved yourself, you've just gained a few extra marks. The other good phrase to put on, it's just my recommendations, whether you guys do it or not, it's totally up to you. I'm just recommending myself to you, is, so I've asked about it in specific complaint. Is there anything in the history that I might have missed that you think might be important? Please let me know. That is a way of me saying to the patient and the examiner, listen, I've done my best, but I'm sure if I missed something, this is the time to tell, please. And please give me a marks because I've covered everything right now. This is just the way of me covering up my loopholes. Listen, nobody can be perfect. If somebody says they're perfect in OSCE, I would like to meet them. I mean, it's a stressful environment, especially in OSCE. It's a high adrenaline exam. It's a high stakes exam because it's a life-changing exam. Your family is dependent on it. Your career is depending on it. Your promotion is depending on it. Lots of pressures on it. Okay? So, nobody's perfect, but you need to find phrases or things which will make sure you cover those bases. Okay, then comes to the main bit. You've just done a history, right? You cannot make a diagnosis just on a history. So you ask the patient, I would also like to examine you with a chaperone, with a female chaperone. Will that be okay with you? Okay, all right. She will say, yes, it's fine. Obviously, you're not going to examine them. You're just saying to examine, I would like to examine. Then you would like to do some investigations, right? Simple things, FPC. Full blood count. Why am I doing full blood count? I normally do it for two things: infection, WBC, and hemoglobin. I mean, I'm not concerned about lymphocytes, erythrocytes, neutrophils. I just want to look at the WBC and hemoglobin for the full blood count, okay? And I don't want to waste my critical time explaining the other intricacies of the full blood count. I don't have time. Time is gold in OSCE. I want to save every second. Full blood count, I just want to check your hemoglobin and your WBC count for infection. I also want to do some kidney function test because that's is a standard test you do in NHS. Chest pain, cardiac, I would like to do troponin, heart enzyme, okay? ECG and a chest x-ray. ECG to look at the tracing of the heart, chest x-ray to look at the heart and the lung shadows, or heart and the lungs, because I think these are the only things you need to really be concerned about, just with pneumothorax, pleural effusions, cardiomegaly, okay? This is not the time or place to show off your medical knowledge. The chest x-ray is there for 10 different things. I would like to do 10 different. No. Let's not go into those. You need to be specific. It's a targeted operation. You need to have your targets in front of you and just go and bang. Okay, right. Then comes. So I've done closing remarks, concerns, anything in the history. I want to do examination. I've talked about the investigations. The thing I did not mention in this scenario is differential diagnosis, okay? Well, Mrs. Smith, I think it could be one of these things. First of all, I want to make sure it's nothing to do with the heart, hence I need to wait for the ECG and troponin to come back. Other things could be muscular, it could be gastric, okay? But those are things which I will not be more concerned about. What things I will be more concerned about is just to make sure you're not having any cardiac problems. I know it's not a PE most likely because it's not a pleuritic chest pain. There's nothing which makes it worse or better. So I've already excluded PE based on my history, okay? So when you give a list of differential diagnoses, the most high-stake differential diagnosis comes first. The most important differential diagnosis to rule out in this patient is cardiac, because she's 55, she's a diabetic hypertensive, she's coming with an atypical chest pain. So that's where the goal is. That's where, if you go in and say, I want to look for musculoskeletal costochondritis, gastritis, and you don't mention about cardiac, it probably will be fair for the examiner not to pass you, okay? Because this station is to make sure you know this patient is a risk factor for cardiac disease. I hope that's clear. I think I've covered most of the things, but I would like to take questions and discuss further on. So please feel free to ask questions.
Hi, Doctor. I have two questions. The first one, when you introduce, do we have to ask the date of birth, or simply can ask how old are you? What's your name and how old are you? Is that fine? Or do we have to ask exactly the date of birth? And the second question is, do we have to request the chaperone even for history stations apart from examination stations? Yeah.
Excellent. Thank you very much, sir. Very good questions, okay? Now, introduction is your own preference. You can choose any of the three scenarios I mentioned. Identification, okay? As long as you do some sort of identification, that's okay. As long as you just confirm the name of the patient, that's absolutely fine. If you just want to confirm name and date of birth, that's fine. If you want to confirm name and age, that's absolutely fine as well. But I prefer candidates asking name and date of birth, okay? Because you can't ask the MRN or medical record number, because that's not going to be there. There could be a couple of patients with the same surname or same name, so hence date of birth becomes important. It's just my way of polishing off the finished article. Now it will come down to each candidate's personal preference, whether they're comfortable just asking the name or date of birth. But just my personal preference would be name and date of birth. Okay. The second question, it's not necessary to have a chaperone in a history taking station unless you suspect there's something else going on here. Okay. As a whole, as a standard, you can take a history from a female, if you are a male, without a chaperone. But for examination of a female, it's compulsory. Okay. And for certain examinations in the male, you need to have a chaperone, such as a PR exam, okay, or looking at the genitalia. You need, even if you're doing a male examination of those, you should get a chaperone, or at least ask for a chaperone. Whether they provide you or not is different. Okay. So, introduction, personal preference. I prefer name and date of birth. Not necessary to have a chaperone in taking history, but compulsory to have a chaperone when you examine a female patient. Okay? I hope that answers the question. We'll move on to the next question. Yes, go ahead.
The first one is, do we have to take sexual history in every history taking station? And my second question is, while explaining the differentials, do we have to, can we just say that yes, I will rule out the cardiac thing, then I will rule out the gastric thing, or we have to specifically mention that I will rule out MI, pericarditis, or gastritis, or esophageal rupture? Do we have to do like this?
Good question, excellent question. Right. Sexual history is not important to be asked in every station, right? Sexual history is for specific histories, such as in a male patient, if they come with hematuria, I mean, you need to ask the sexual history because it could be STDs, sexually transmitted disease. Okay, if it's so, what I in the way what I covered in this station about sexual history is I asked about her marital status. Okay, so she said she's divorced. She could have said she's married. If she would have said no, I'm unmarried. Okay, sexual history becomes really important in male patients with hematuria, any patient with joint pains. Okay, especially if they're young. In females with vaginal bleeding, sexual history becomes important. So to answer this question, does sexual history needs to be asked in every history? No, it's dependent on the history you're taking. I mean, in chest pain, asking a sexual history would just look odd. I mean, it would just look odd. I mean, in headache, you can ask a sexual history because you can have subdural hemorrhage, subarachnoid hemorrhage when you have sexual activity, vigorous sexual activity, sudden onset of headache while you're having sexual activity. The headache becomes important. But in chest pain, I just thought it would look odd. The way I wanted to cover this by asking the marital status. Okay. Now the differential diagnosis. Okay, important question. When you're giving a list of differential diagnoses, you need to make sure you first two or the first one focuses on the most important differential diagnosis which the examiner or the college is asking you in that station. In my station which I did, it's the cardiac because she's coming with chest pain, she's coming with all the risk factors. So for me, cardiac becomes the top. The way I'm going to rule this out is A, if the patient is having chest pain more than 6 to 8 hours, then a troponin, standalone troponin will be important, will be enough to rule it out. But if the patient has just had a chest pain half an hour ago, she's got all the risk factors and she's still in chest pain, I cannot rule out a cardiac disease unless I do one troponin now and then troponin afterwards, 3-4 hours, depending on which facility you're working at. Okay, so ruling out the most important differential diagnosis is important. Coming back to the other 2 or 3 second or third differential diagnosis, one can never rule out a gastritis unless you do an endoscopy.